It's a vein specialist's worst nightmare. The thought of accidentally injecting sclerosant into an artery instead of a vein fills all phlebologists, including me, with horror. A recent article by Professor Kurosh Parsi and colleagues has highlighted the dangers and consequences of intra-arterial injection of sclerosants. To put it simply, it's a disaster, a catastrophe. Kurosh Parsi wrote this 37-page document with the help of 31 colleagues and advice from 2 practicing barristers. It's the most comprehensive and up-to-date publication currently on the dangers and consequences of intra-arterial injection of sclerosants. The manuscript is a must-read by all practitioners who perform sclerotherapy. I've read it, and here are my takeaways. Prevention is better than cure, and this is more true than ever with regard to the accidental injection of sclerosants into an artery instead of a vein. There's no cure to remedy the intra-arterial injection of a sclerosant. Some degree of tissue loss or even limb loss will follow. So what can we do? Well, obviously, don't inject an artery. Pretty obvious, isn't it? So how do we avoid injecting arteries? Well, for any vein deeper than skin level, I use ultrasound guidance. Now, I filmed this nearly 10 years ago. It emphasises the 4 criteria I use before and during sclerotherapy injection. Let's have a look. So I'm going to do the foam sclerotherapy now, and I like to do foam sclerotherapy using a blue butterfly cannula. It's called a butterfly cannula because it has a passing resemblance to a butterfly, and it is blue. Which means that it's a 23 gauge, is that right, Pam? 23 gauge cannula, and it's got a piece of transparent tubing which allows me to see that I've cannulated. The butterfly wings allow me to use very delicate movements as if writing with a pen, so it's very easy, in my opinion, to cannulate small veins with a blue butterfly. Okay, so I'm going to do it in the standard way. I'm looking at the offending vein, or the vein, the target vein, as I call it. I'm going to adjust the image on the ultrasound, and then again in transverse section, my preferred method, I'm going to use the butterfly needle to cannulate the vein. It's a very fine needle, it shouldn't cause too much in the way of discomfort, and the vein is 2 millimeters that we're cannulating, and we've got the confirmation that we're in the vein by the very slow movement of dark blood in the vein. So 3 criteria for cannulation have been passed. I've seen the tip of the cannula in the vein on ultrasound. That's criterion number 1. Number 2, I've seen dark blood come back, suggesting we are in fact in a vein, it's not bright red. And criterion 3 is that it's non-pulsatile, so we're not in an artery. I don't wish to cause Carol any alarm, but in the event that an artery was cannulated and injected, consequences could be disastrous. So I'm very careful. We use a cannula, and we have those 3 strict criteria to confirm before we do any injections of foam sclerotherapy. The final criterion, and we're very, very cautious about this, is that we see the foam in the vein, and also that the injection is painless. This should cause Carol no pain whatsoever, and we can see the foam going into the vein, confirmed on ultrasound. So we now have in total 4 criteria for successful cannulation and injection of foam sclerosant. I very frequently combine laser with foam sclerotherapy and phlebectomy all in one session. I think it's very safe. I think it deals with any veins which are slightly deeper in the leg that are not accessible to laser or phlebectomy. And I've got no evidence yet to suggest that it reduces the recurrence rate, but
a priori it would suggest that it does.
Look, obviously when selecting the target vessel, you want to confirm that it's compressible with gentle transducer pressure and that it's not pulsatile. Sometimes pulsation of an artery is not obvious, but you can exaggerate pulsation of an artery with gentle pressure of your transducer in transverse section. And in fact, that reminds me that when you are compressing veins, make sure you do it in transverse section. For ultrasound-guided foam sclerotherapy, I always recommend the use of cannulas for safety reasons. And to repeat, the 4 criteria are that the needle is confirmed within the vessel on ultrasound. I prefer transverse section. Once I've cannulated the vessel, I like to see slow backflow of dark blood into the cannula. The backflow should be non-pulsatile, and when I inject with foam, I can see the foam within the vein. I would also recommend flushing the vessel with saline, which should only require very gentle pressure on the plunger of the syringe. The Parsi publication includes a very useful table summarizing the ultrasound appearances of veins versus arteries. Now, all of this applies to larger veins, veins that you might inject with foam sclerotherapy under ultrasound guidance. But what about smaller veins? What about telangiectasia? Well, when injecting small veins in the skin, inject low concentrations with a slow action and make sure you use low volumes at each injection site. In this way, the mantra is low, slow, low, we hope to mitigate the risk of veno-arteriolar reflex venospasm, which is thought to be the main reason for small scabs and small ulcers after microsclerotherapy, rather than extravasation. This video covers these points.
Place the skin under tension to provide a flat surface to facilitate needle puncture. This is accomplished by spreading the fingers and thumb of the non-injecting hand and applying counter-traction with the little finger and hypothenar eminence of the injecting hand. Use a 30-gauge needle, 1/2 inch, and inject with the bevel of the needle turned upward. Place the needle flat on the skin. The injection should be performed slowly, and intravenous injection should be confirmed while the injection is in progress. Only inject when you are watching the needle tip. Successful intravenous injection results in blanching along the course of the thread vein. Blanch no more than 2 cm by 2 cm area of telangiectasias at a time. That's because the solution is most active close to the injection site. And this is worth repeating. The needle tip should be observed at all times. The injection must be stopped immediately if a bleb appears, which indicates extravasation, or if there is blanching of the skin, in contrast to blanching of the vessels, which indicates veno-arteriolar reflex venospasm, or injection directly into a small arteriole.
Now, when considering microsclerotherapy, there's one area that I think you should pay particular attention to, and that's around the ankle. That's because the neurovascular bundles are very close to the surface, and even quite experienced people need to be very careful around the ankle. My colleague Zola Mazimbla produced this video showing the technique of injecting spider veins around the ankle. It's not for beginners. It requires meticulous technique, because if you inject too deeply, you run the risk of injecting an artery, even during microsclerotherapy. Now, in all cases of sclerotherapy, you should suspect arterial injection if the injection is painful. Sclerotherapy may be uncomfortable when the needle pricks the skin, but the actual injection of sclerosant into the vessel shouldn't be painful at all. If it is, something's wrong. You should always stop immediately if any of your injections are painful. And I usually preface the injection session by saying to my patients, don't be brave. Tell me if you experience any pain whatsoever. To me, pain on sclerotherapy injection is a warning sign that something's wrong and that I need to pay attention and stop immediately. We should always suspect arterial injection if the skin changes colour. For microsclerotherapy, you want blanching of the vessels. But if you get blanching of the skin, it means something's wrong. Maybe the sclerosant has passed from the venous side of the circulation into an arteriole. For larger vein injections, watch for mottling or redness. The Parsi paper has some wonderful illustrations. Now, in my opinion, much of the guidance in Parsi's paper is outside the scope of independent practitioners who perform nearly all of the microsclerotherapy and who perform most of the ultrasound-guided foam sclerotherapy, at least in the UK. So what can we do in independent practice if we suspect intra-arterial injection? Well, I suggest you print a copy of Parsi's paper now and file it away somewhere accessible, somewhere where you can get your hands on it quickly. One of my colleagues, Zola Mazimba, has already uploaded it to his online patient record system where he can access it quickly and print it out. Secondly, you should already have a policy and procedure for transferring patients from your clinic to your local hospital. If you don't, write one now. And make sure everybody in your clinic knows about it. Now, as a side note, I would say that anaphylaxis is a very rare complication of sclerotherapy, but it's more likely to happen, I would suggest, than intra-arterial injection after sclerotherapy. So you should already have a transfer policy for those rare occasions when you have a severe emergency or a severe complication and you need to get your patient transferred to your local hospital. If you do suspect a intra-arterial injection, consider taking photographs and baseline observations such as blood pressure, pulse, and perhaps also pulse oximetry, and make a clinical assessment of the circulation, including the skin color, the skin temperature, capillary return, and the presence or absence of pulses. Don't waste time doing an arterial duplex scan. If it's not something you're doing regularly in your venous practice, this is not the time to start. Now, if you suspect a major arterial injection of sclerosant, then you need to get that patient transferred to hospital pretty damn quickly. Call an ambulance. Send a copy of the Parsi paper and your transfer documentation with the patient. The receiving vascular unit will find this paper really helpful. And with regard to medication, I don't think it's appropriate to keep a long list of emergency medication which will require stock rotation, checking for expiry dates and so forth. But I do think it's worth keeping at least heparin and GTN as stock pharmacy items. Now, if you suspect that you've got skin blanching of a small area after microsclerotherapy, then you need to be, obviously you've stopped immediately because it's been painful and you've noted the white blanching of the skin. You've stopped immediately. You need to be honest with your patient. You need to tell them what's happened and you need to warn them about the risk of a small scab or a small ulcer. And you need to see that patient regularly to assess their progress. Again, do baseline observations, consider taking photographs, and document very carefully what happened, what you injected, how much, the concentration, and what you noted. If you're in any doubt, always seek the advice of a more experienced colleague. And if the patient does get an ulcer, always consider referring for a second opinion. Now, the document is a long one. As I've said, it's 37 pages. If you've read it, I'd be really interested to hear what your views are. Did you find it helpful? Do you think it's overkill? Do you have a policy? Do you think I've left something out? I'd really like to hear your views. Leave a comment in the box below. I read all of these and I promise to get back to you as soon as I can. Thank you for watching. I hope you found this useful. Consider subscribing. That way you'll be among the first to see my next video.